Before we dive in, let's just take a moment to ground ourselves. Take a deep breath in. Okay, and let it go. Now, picture a patient in your care. They've got this rapidly spreading red, swollen leg. You are right there on the front line. And your decision, it could actually prevent sepsis. So let's get focused, get ready, and prepare to handle that moment with real confidence. All right. Did you know that cellulitis can sometimes look a lot like a DVT? It's tricky. Or how about this? Treating a diabetic foot infection. It's often much more about source control, cleaning things up than just throwing antibiotics at the problem. Skin and soft tissue infections, SSTIs, they show up constantly on the NAPLEX. And I mean, even more often in real life, right? They can be anything from just like a minor annoyance to a really life-threatening emergency. So in this deep dive, we're basically building your ultimate toolkit. We'll help you decode these key infections, everything from familiar stuff like impetigo all the way to terrifying necrotizing fasciitis. And the goal is to help you confidently pick the right drugs for the right bug at exactly the right time.
That's absolutely true. SSTIs are definitely among the most common infections we encounter. And from a pharmacist's perspective, these aren't just diagnoses on a chart. They're real chances to step in early and make a difference. The skin, our biggest organ, it's usually a fantastic barrier. But when that barrier gets compromised, maybe it's too much moisture or decreased blood flow, maybe just a small cut, bacteria they can move in pretty fast. And certain underlying conditions, especially diabetes, they really can just roll out the welcome mat for these infections.
That makes total sense. So thinking about where these infections start, are we generally dealing with like the same few bacteria across the board? Or does it change a lot depending on how the skin got damaged in the first place?
Oh, that's a really good question because it definitely shapes how we approach treatment. We usually talk about primary infections versus secondary infections. Primary ones, they hit otherwise healthy skin, usually caused by just one organism, like Staphylococcus aureus or maybe Streptococcus Pyogenes. Think of it like a direct hit. Then you've got secondary infections. These happen in skin that's already damaged, maybe a chronic wound or a surgical site. And these are often polymicrobial, meaning you've got multiple types of bacteria involved, which, makes them more complicated to treat.
Gotcha. Okay, so by the end of this deep dive, everyone listening, you're going to be able to identify and tell apart the different types of SSTIs. You'll know if they're purulent, pus-filled or non-purulent, and figure out how severe they are. You'll also be able to pick the right empiric antibiotics. That's your best guess initially. And then the definitive therapy once you know more. Plus, we'll nail down exactly when you need to worry about MRSA coverage, and we'll cover special situations like diabetic foot infections, nasty bite wounds, and necrotizing infections. And finally, you'll learn how to keep an eye on your patient's progress, knowing when to step up therapy or maybe back it off.
Right. And before we jump into the specific infections and treatments, let's quickly run through some key drug names, just to make sure we're all saying them the same way. Maybe repeat them with me once or twice, helps it stick. CLI indemycin, TLI indemycin, okay. The vancomycin, good. Diacylloxacillin, linezolid, and cefalexin. All right, got those. With those pronunciations hopefully locked in, let's get into the details.
Okay, first up, impetigo. You might have heard it called the honey-crusted infection. This one's very superficial, just on the top layer of skin. Super common in kids, especially when it's hot and humid out. It usually starts as these little blisters, right? And they pop really easily, then form those characteristic golden yellow crusts over the top. It's pretty hard to miss once you've actually seen it.
Indeed. And the usual suspects here are Group A's Streptococci. We often just say GAS and Staphylococcus aureus. For really mild cases, sometimes simple stuff works best first. Soaking the spots with soap and water, keeping the skin moisturized with emollients, non-drug approaches.
But if you need to step it up pharmacologically, for those mild localized cases, topical mupirocin ointment, that's usually very effective. But if it's more spread out or seems more severe, you'll likely need systemic antibiotics, things like oral cephalexin or maybe dicloxacillin. Now, what about MRSA? That's always the question. When should we think about covering for MRSA with impetigo?
Yeah, that's a crucial point. If you start seeing systemic signs like a fever, the patient feels generally unwell, or the lesions are spreading really fast, that's your signal. That's when you should consider adding MRSA coverage empirically. So for example, clindamycin would be a reasonable choice to cover for potential community-acquired MRSA or KMRSA.
Okay, so from the very superficial impetigo, let's dig a little deeper, down into the hair follicle. That's where we find infections like folliculitis and its sort of bigger, meaner cousins, furuncles and carbuncles. What's the difference between those three?
Right. So folliculitis is just a superficial infection right in the hair follicle. It's like tiny red bumps, maybe some pustules, pretty minor usually. A furuncle, that's what most people call a boil. It's deeper, more localized, affects just one hair follicle, and yeah, it can be quite painful. And then carbuncles, those are the really nasty ones. They form when several furuncles that are close together kind of merge into one big, painful, often draining lump, much larger.
And what's usually causing the trouble in these hair follicles? Is it typically S. aureus again?
Absolutely. S. aureus is definitely the most common culprit. But, occasionally you might see Pseudomonas aeruginosa, especially linked to like hot tubs that aren't chlorinated well. We call that hot tub folliculitis, or even candida sometimes in people who are immunocompromised. For treatment, warm, moist compresses can often help folliculitis, and those smaller furuncles drain on their own. But for the larger furuncles, and definitely for carbuncles, incision, and drainage IND, that's the main treatment, getting the pus out, antibiotics. They come into play if there are systemic symptoms, fever, chills, or if the infection is spreading out into the surrounding skin, like cellulitis. In those cases, yeah, you'll need systemic drugs active against S. aureus, again, like dicloxacillin or cephalexin.
And if you suspect the dreaded community-acquired MRSA, CAM-RSA, what are the go-to empiric choices while you're waiting for those culture results to come back?
Good question. For suspected CAM-RSA, your main oral empiric options are usually trimethoprim sulfamethoxazole, TMPS-MX or doxycycline, maybe minocycline or clindamycin. These generally cover most community strains of MRSA pretty well.
Okay, moving on. Let's talk about when infections start to, travel. Lymphangitis. That's inflammation of the lymphatic channels, usually caused by strep species, right? And you see those classic red streaks running up from the infection site toward the lymph nodes. It can look pretty alarming. Why is treating this quickly so important?
Because if you don't control lymphangitis, it can progress really rapidly to a systemic infection, bacteremia, and potentially serious complications. The goal is just prompt eradication. Treatment-wise, you want to start parenteral penicillin pretty quickly, ideally within 48 to 72 hours. Then, once the patient starts improving clinically, you can switch over to oral penicillin to finish a 7 to 10-day course. And if someone's allergic to penicillin, clindamycin is usually a good alternative there.
Okay. Then there's erysipelas. This one's different, right? It's limited to the very superficial skin layer and the cutaneous lymphatics just beneath. And unlike cellulitis, erysipelas presents with those really clearly demarcated, raised, bright red, often burning lesions, sharp borders. And again, GAS, group A strep, is the most common cause here too.
That's right. For mild to moderate erysipelas, oral or even intramuscular penicillin is the way to go, usually for 7 to 10 days. If it's more severe infection, then intravenous penicillin is typically needed. Now, alternatives for penicillin allergies include clindamycin and macrolides, like azithromycin. But you really need to be cautious. Why? Because GAS can have pretty high resistance rates to these drugs in some areas. Using them could lead to treatment failure. So you always need to consider your local resistance patterns.
Okay, so from the sharp, superficial lines of erysipelas, let's move to cellulitis. Specifically, the non-purulent kind, where the lines often get a bit blurry. This is an acute infection affecting the deeper epidermis and dermis, and it can potentially spread down to the superficial fascia. It's definitely a serious SSTI because the infection has this tendency to spread through the lymph system and even into the bloodstream if you don't treat it effectively.
Exactly. The most common bugs here are GAS and S. aureus, and yes, that includes CAM-RSA. Cellulitis usually shows up as a painful, tender area on one side of the body, unilateral, with redness, swelling, warmth that spreads pretty quickly. The key difference from erysipelas, though, is that cellulitis has poorly defined margins. It kind of fades out into the normal skin. Oh, and if you do see cellulitis with abscesses or obvious pus, that usually points more towards S. aureus being the cause rather than strep.
Right. So the goals for treating cellulitis are, obviously, get rid of the infection quickly, but also prevent it from progressing to something worse, like osteomyelitis, bone infection, or septic arthritis in a joint. Beyond the antibiotics, what non-drug things are important here?
Good point. Non-pharmacologic treatment is key. Elevating and immobilizing the affected limb helps reduce swelling. Sterile saline dressings can be helpful on any open lesions. And in severe cases, you might need surgical debridement to remove dead tissue or drainage if there's an abscess involved. Now, for the drugs, for mild infections, oral options like cephalexin or dicloxacillin are usually solid choices. But for moderate to severe cases, you're definitely looking at IV antibiotics like ceftriaxone or cefazolin.
Okay, and the big question again, When is MRSA coverage really needed for cellulitis? Because that comes up all the time.
Yeah, it does. You should definitely think about MRSA coverage if a few things are true. One, if there's a high rate of MRSA in your local community. Two, if the cellulitis resulted from penetrating trauma, like a deep cut or puncture. Three, if the patient has a history of IV drug use. Or four, if they present with significant systemic symptoms, high fever, chills, looking really sick. If you need empiric oral agents for MRSA, think TMPS, MXDS, doxycycline, minocycline, or clindamycin. And if you need IV empiric MRSA coverage, your big guns are vancomycin, linezolid, daptomycin, or ceftaroline. Treatment duration, usually around 5 to 7 days. But it might need to be longer for people who are immunocompromised or if the infection is really severe. And for complicated cellulitis, yeah, you'll start with IV antibiotics, then switch to oral once the patient is stable and the skin signs are clearly improving. All right, let's pivot to abscesses. These are like the classic purulent SSTIs, full of pus. And what's kind of interesting, maybe counterintuitive, is that the primary treatment isn't antibiotics first. It's incision and drainage. IND.
Right. That's right. You know, sometimes the best antibiotic really is a scalpel. Get that pus out. You only add antibiotics after the drainage if there are systemic signs like a fever, or if the patient is high risk, maybe immunocompromised, or if it's a really huge abscess. And the options here, again, targeting is Aureus mainly, so things like TMPSMX, clindamycin, or doxycycline are common choices. Okay, now for something much, much more serious. Necrotizing fasciitis. This is rare, thankfully, but it's incredibly rapidly progressive and absolutely life-threatening. It's an infection deep down in the subcutaneous tissue and the fascia, the connective tissue sheath around muscles. What's really alarming is that while it's more common in folks with chronic diseases like diabetes, perfectly healthy people can get it too. It often starts from what seems like just a minor injury, but then bacteria just multiply like crazy, release toxins, and cause this widespread tissue destruction and severe systemic toxicity. People call it flesh-eating bacteria, and well, that's sadly pretty accurate.
Precisely. And there are two main types to know about. Type I is polymicrobial, lots of different bacteria, both aerobic and anaerobic, often seen after surgery or deep penetrating wounds, typically in patients with comorbidities like diabetes. Type 2 is usually monomicrobial, meaning just one bug, typically GAS, group A strep. This type can follow even minor trauma. But here's a critical point, especially for the NAPLEX and for practice now. Community-acquired MRSA is an increasing cause of type 2 neck fasc. It absolutely must be covered empirically. Don't forget MRSA.
Which brings us to maybe the most critical point of all, prompt surgical intervention. It's not just important, it is absolutely essential, like emergent. Any delay significantly increases the risk of death. We really cannot stress that enough. Get the surgeons involved immediately.
Absolutely. And right alongside that urgent surgical debridement, you need to start empiric antimicrobial therapy immediately. No waiting. The standard approach is often broad. You'll use a parenteral beta-lactam beta-lactamase inhibitor, think piperacillin, tazobactam, or a carbapenem like meropenem, that's in combination with clindamycin. And we really emphasize clindamycin here because it's a protein synthesis inhibitor. It does that mean? It helps decrease the production of bacterial toxins, which is crucial in neck fasc where toxins cause so much damage. And you also add a parenteral MRSA active antibiotic, vancomycin, linezolid, or daptomycin. So it's often triple therapy initially. Once you get cultures back and know the specific bugs, you can streamline the treatment. Duration, usually about 7 to 14 days, or until the patient is showing substantial clinical improvement stable for 48 to 72 hours and no more surgery is planned. Oh, and the clindamycin part, that can often be stopped after about 72 hours if the patient is hemodynamically stable.
Okay, deep breath. Let's shift gears now to diabetic foot infections, or DFIs. These are incredibly common, often very severe, and really costly complications of diabetes. It stems from that tough combination of neuropathy, nerve damage, angiopathy, blood vessel disease, and immunopathy, weakened immune system. It's just a complex challenge pharmacists see all the time.
It really is. And the microbiology here can be tricky too. If it's an acutely infected ulcer, it's often aerobic gram-positives like S. aureus and Strep. Pretty straightforward. But those chronically infected ulcers, they're frequently polymicrobial. You might find Enterobacterales, gram-negatives, maybe Pseudomonas aeruginosa, and definitely anaerobes in the mix, much more complex.
And the potential complications are really serious. The infection can spread, it can lead to osteomyelitis, that bone infection again, and sadly, sometimes amputation is the only option. So our goals are clear. Resolve the infection, yes, but also avoid those terrible complications and ideally prevent future infections.
And something that's often underestimated, but it's absolutely crucial here, non-pharmacologic therapy, specifically meticulous debridement, cleaning out all that dead tissue. You can give the best antibiotics in the world, but if you don't clean up the wound bed, remove that necrotic tissue,
You're really fighting an uphill battle. Source control is paramount.
Totally agree. And prevention is just so vital too, isn't it? Things like comprehensive foot care programs, making sure patients get regular foot exams, educating them on proper self-care for their feet, plus optimizing their blood sugar control and definitely encouraging smoking cessation. All key preventive strategies. Now, when it comes to actually treating an active DFI with drugs, for mild infections, that's Pyogenes grade 2, usually meaning no systemic signs, just a limited local infection. It's typically outpatient oral antibiotics. And you're aiming for narrower spectrum drugs covering the likely culprits, S. aureus and Strep.
Exactly. So if MRSA isn't really suspected, oral sulflexin or dicloxacillin are good starting points. If MRSA is a concern based on history or local rates, then you'd lean towards TMPSMX, DS, doxycycline, or clindamycin. Now, for moderate to severe DFIs, Pyogenes grades 3 or 4, this means deeper infection, maybe some systemic signs, possibly bone involvement is suspected. These patients often need to be admitted to the hospital, at least initially, for parenteral IV antibiotics. Then you can transition to oral later. And here, yeah, you need broad spectrum coverage right off the bat. Gram-positives, gram-negatives, and anaerobes.
Okay, so for those moderate to severe cases, what are some of the go-to empiric IV regimens, especially if you're worried about MRSA or maybe those tricky gram-negatives like Pseudomonas?
Right, for broad coverage, you're often looking at combination therapy. A very common approach might be vancomycin that covers your MRSA, combined with something like piperacillin tazobactam, which gets gram-negatives, including Pseudomonas and anaerobes, or maybe a carbapenem like ertapenem if Pseudomonas isn't a high concern, plus vancomycin. If Pseudomonas is a big concern, maybe something like cefepime plus metronidazole for anaerobic coverage, again, usually with vancomycin for MRSA. The key is really covering all your bases empirically until those cultures come back and tell you exactly what you're dealing with. And if you see signs of necrosis or gas gangrene, you absolutely ensure you have potent anaerobic coverage. Duration here can really vary. Could be 7 days, could be 28 days, could be even longer if osteomyelitis is confirmed. It depends heavily on the severity and response to treatment.
All right, our last specific SSTI category for today, animal or human bites. We all know dog bites happen a lot, but did you know that cat bites and human bites actually carry a higher risk of getting infected? Especially those deep puncture wounds or bites on tricky spots like the hand. It's not just about cute puppies causing problems.
That's right, and the absolutely crucial first step, no matter the bite.
Yeah.
Thorough irrigation, washing it out really well, and debridement, cleaning away any damaged tissue.
Yeah.
And here's something that might surprise you. Most bites actually don't need antibiotics prophylactically, unless they're already showing signs of infection. It's not an automatic prescription just because someone got bit.
Interesting. But there are times when prophylactic therapy is recommended, right?
Definitely. Prophylaxis is generally needed for all cat bites, all human bites, deep puncture wounds, like from a cat tooth, any bites involving the hand or face, or any bite that needs surgical repair anyway.
Yeah.
The pathogens you're worried about are typically the normal mouth bacteria of whatever bit the person, animal or human, and maybe some of the victim's own skin flora getting pushed in.
So what's the go-to drug, the one we need to remember?
The drug of choice, the one you absolutely need to have locked down for the NPLX and for practice, is amoxicillin clavulanate. Think of it as the augmentin rule for bites. It covers the typical oral flora, including Pastorella species, which are common in animal bites, and anaerobes. It's usually the best single agent.
Okay, augmentin rule for bites. Got it. And what about patients allergic to penicillin? What are the alternatives?
Depends on how severe their allergy is. But generally, alternatives might include a second or third generation cephalosporin, if it's not a severe allergy. Or maybe a fluoroquinolone like levofloxacin or doxycycline. But importantly, these often need to be combined with either metronidazole or clindamycin to make sure you get good anaerobic coverage, which amoxicillin clavulanate has built in.
Makes sense. Okay, let's just quickly touch on a few special considerations in managing SSTIs overall. When you're picking an antibiotic, it's not just about whether it works, right? You think about side effects, potential drug interactions. Can the patient take pills, or do they need IV? Even pregnancy category sometimes. It's a whole clinical picture.
Exactly. And a huge piece of that puzzle nowadays is, unfortunately, the rise of community-acquired MRSA, CAM-RSA. It's caused a massive increase in SSTIs over the last, say, 2 decades. So this means if you practice in an area where CAM-RSA is common, your empiric treatment for many purulent SSTIs probably should include an antibiotic that covers MRSA,
Also remember that clindamycin thing we mentioned. If local resistance rates to clindamycin are high, maybe over 10% or 15%, or if you get a culture back that shows Aureus with a positive D test, that indicates inducible resistance, meaning clindamycin might look like it works in the lab but could fail in the patient. So you want to avoid it in those cases.
Good points. Now, what about cellulitis in specific populations, like people who inject drugs, PWAD, or immunocompromised patients? Does that change the approach?
It often does, yes. These groups are at a higher risk for polymicrobial cellulitis, meaning more than one type of bacteria is involved. For PWID, infections can involve not just skin flora, but also bacteria from the mouth or contaminated injection practices. So you might see S. Aureus, including MRSA, Strep, but also anaerobes and maybe even gram-negatives. Similarly, immunocompromised patients just have weaker defenses, making them prone to more complex infections. So in these populations, if they present with severe cellulitis and systemic symptoms, you'll often need broader spectrum antibiotics right from the start to cover a wider range of potential pathogens. And finally, let's briefly circle back to osteomyelitis, that bone infection we mentioned as a serious complication of SSTIs. The main culprits are often S. aureus and Streptococcus, just like in the skin infections they stem from.
Right. And it's helpful to know the three main ways it happens. Hematogenous, where bacteria travel through the blood, often seen in kids affecting long bones. Then there's contiguous, mostly in adults, where infection spreads directly from adjacent infected tissue, like a deep wound or after surgery. And third, secondary to vascular insufficiency, common in older adults or people with diabetes, typically hitting the feet and lower legs due to poor circulation.
Exactly. And before you even start systemic antibiotics for suspected osteo, getting a deep culture, ideally from the bone itself, and surgical intervention or debridement are really crucial for diagnosis and treatment. Empiric therapy then targets the likely pathogens based on how the infection started and patient risk factors. And the duration of treatment, it can vary a lot. It might be just 2 to 5 days if all the affected bone is surgically removed, but it could be as long as 6 weeks or sometimes even more if infected bone remains. It's definitely a long haul for treating bone infections.
Okay, wow, we've covered a ton of ground. Let's see if some of it stuck with a quick quiz. Ready? Question 1. A 35-year-old comes in with a fluctuant abscess, meaning it feels like fluid under the skin, and they have a fever. What is the best initial step? A. Start oral cephalexin. B. Perform incision and drainage. C. Start 4-view vancomycin. Or D. Prescribe topical mupirocin. What do you think?
Okay, the answer here is definitely B, incision and drainage. For a fluctuant abscess, getting the pus out is always the first and most important step. Remember our scalpel mantra.
Absolutely. Question 2. Which adverse effect is most notably associated with clindamycin, even earning it a black box warning? A. Rash, B. Hyperkalemia, C. Difficile colitis, or D. Hypoglycemia?
The infamous clindamycin side effect. The answer is C. Difficile colitis. Clindamycin has a particularly high risk of causing the severe diarrhea, so it's something you always need to counsel patients about and watch for.
Crucial point. Okay, question 3. A patient with diabetes presents with a swollen foot. It has foul-smelling drainage, and you can actually see exposed bone. What's the best next step? A. Start doxycycline. B. Prescribe topical mupirocin. C. Hospitalize the patient and start broad-spectrum IV antibiotics. Or D. Reassure them and have them follow up in a week.
Yeah, this one's serious. The answer is C. Exposed bone, foul drainage, and a diabetic foot. That screams severe diabetic foot infection, potentially with osteomyelitis. This patient needs to be hospitalized immediately for IV antibiotics and likely surgical evaluation. No waiting around.
Definitely an emergency. Let's do one more, maybe 2. A child presents with these sort of golden yellow honey-crusted lesions, mostly around their nose and mouth. What's the most likely diagnosis? A. Cellulitis, B. Erysipelas, C. Impetigo, D. Folliculitis.
That description is classic. The answer is C. Impetigo. Those honey-crusted lesions are the absolute hallmark sign, especially in kids. It's almost pathognomonic, as they say.
Perfect. Last one. Which characteristic is most helpful in differentiating erysipelas from cellulitis? A. Presence of fever, B. Unilateral pain, C. Rapidly spreading redness, or D. Clearly demarcated raised margins.
The key differentiator is D, clearly demarcated raised margins. While both can have fever, pain, and redness, erysipelas has those really sharp, distinct raised borders. Cellulitis tends to have more diffuse, poorly defined edges. That visual difference is super helpful.
Excellent. Okay, time for our quick reinforcement pearls. Remember these key takeaways. Purulent, think MRSA. Non-purulent, think strep. It's a good starting point. Bites, think augmentin, or you're asking for anaerobes. That augmentin rule. And finally, if you see red plus rapid plus pain, especially pain out of proportion, think nec fasc until proven otherwise. be suspicious. And just like that, that's a wrap on our deep dive into skin and soft tissue infections. We went from simple impetigo all the way to the really complex, sometimes scary world of diabetic foot infections and necrotizing fasciitis. Hopefully you now feel more confident about what to look for, how to approach treatment, and definitely what to watch out for on the NAPLEX. You've built a really solid foundation.
Absolutely. And maybe one last thought beyond just the drugs and diagnoses. Remember how important prevention is. Optimizing personal hygiene, yes, but also meticulously managing those underlying risk factors, like keeping diabetes under tight control. These things are crucial in stopping SSTIs before they even start. It really highlights that holistic approach to patient care, where pharmacists play such a vital role, not just in treatment, but in education and prevention too.
So well said. If this deep dive helped you level up your SSTI knowledge, please don't forget to like, share, and subscribe. And hey, tag a study buddy who needs to get smart on SSTIs too. Next time, we're cracking open bone and joint infections, digging deep into how to tackle osteomyelitis. See you then.